Our patient here is a 2-week-old baby boy who is presented with fever, dehydration, and vomiting, and during the clinical examination, we find a palpable mass in the lower part of his abdomen. Given his age and symptoms, we're immediately thinking of an obstructive cause leading to these findings. So what do we have on the ultrasound? Both kidneys are normal in size, with the right measuring around 5 centimeters and the left about 5.7 centimeters. However, we see bilateral hydronephrosis, that's dilation of both kidneys. Additionally, the superior part of both ureters is also dilated. This clearly suggests there's a downstream obstruction, which is concerning. Now let's move on to the MCUG, the micturating cystourethrogram. This is where the picture becomes clearer. We observe a small bladder, which has a thick, trabeculated wall, an indicator of long-standing obstruction. The posterior part of the urethra is elongated and dilated, but the contrast doesn't pass into the anterior urethra, which indicates an obstruction in the posterior urethra. That's a key finding here. On top of that, there's bilateral vesicoureteric reflux, meaning urine is flowing backward from the bladder into the ureters, and the ureters themselves are dilated and tortuous. There's also dilation and blunting of the renal calyces. Together, these findings strongly point towards posterior urethral valves, or PUV. Let's dive into what posterior urethral valves are. PUV is a congenital abnormality where the normal mucosal folds in the urethra thicken or fuse abnormally. These valves function like a sail, causing near-complete obstruction of urine flow. Importantly, this condition only occurs in boys and is the most common cause of urethral obstruction in male infants, with an incidence of about 1 in 5,000 to 8,000 male births. There are 3 types of posterior urethral valves. Type 1 is the most common and involves mucosal folds that extend antero-inferiorly from the verumontanum. Type 2 is the rarest and involves folds extending antero-superiorly. Type 3, also rare, involves a diaphragm-like membrane located below the verumontanum. Given the prevalence, our patient most likely has type 1. Now, in terms of clinical presentation, this can vary widely depending on the severity of the obstruction. Roughly 1 in 10 cases are picked up antenatally, around a third in the neonatal period, and another third during the first year of life. In our patient, the presentation is early in the neonatal period, with common symptoms like fever, vomiting, obstructive symptoms, and a palpable bladder. The key imaging modality to start with is ultrasound, which shows hydronephrosis and other abnormalities as we've seen. But MCUG is really the gold standard for evaluating the urethral anatomy, and it has confirmed our diagnosis here, showing the classic distended, thick-walled bladder and posterior urethral dilation. In terms of differential diagnosis, we should consider anterior urethral valves, urethral strictures, massive vesicoureteric reflux, and even primary megaureter. But the findings here strongly point to PUV. If left untreated, PUV can lead to serious complications like neonatal urine leakage with ascites, pulmonary hypoplasia, and even renal dysplasia. Poor prognosis is often linked to the severity of vesicoureteric reflux, which, in our patient, is quite significant. Management in this case will require surgical intervention, specifically endoscopic ablation of the valves. If PUV is diagnosed antenatally, management might include early induction of labor if the baby is viable, or even fetal surgery if there's severe oligohydramnios. To sum it up, this baby has posterior urethral valves, the most common cause of obstructive uropathy in male infants. Early detection and intervention are key to preventing long-term complications. And of course, don't forget to subscribe to Radiology Made Easy for more cases like this one, where we dive into complex cases and break them down into something much more understandable. Stay tuned for more radiology insights.